this session we have the opportunity to look more closely at the HealthLinks program that the Victorian Department of Health and Human Services has developed as a response to dealing with the complexities of complex conditions and chronic care, and how we can come up with more flexible funding models to deliver better value to folk who have these conditions. We have two speakers, a principal speaker and a capable assistant. I'd like to first of all introduce Ms. Tanya Sewards. Tanya is acting in the role of manager of the integration projects team in the Victorian Department and is responsible for overseeing the implementation and evaluation of the HealthLinks program clinical care trial. The unit has broader responsibilities to identify funding and policy options that will improve the integration of hospital, community and primary services, a theme that we heard much about in the previous session. Her previous roles across the department have been in the portfolios including mental health and drug workforce, rural health, emergency medicine and housing. Tanya has also held roles in other Victorian government departments including education, justice, Premier and Cabinet and economic development, and she's also worked in research and consultancy roles. Joining Tanya will be Chris Hamilton, who also works in the Victorian Department and is part of the team associated with HealthLinks, and his role is in systems intelligence and the analytics branch. So I'd like to welcome Tanya to the podium.
Thanks very much for having me. I'd like to thank IPA for inviting me to speak today, to Michael for the introduction, and also to Christine Bennett, whose presentation I found really insightful and also reflected a lot of the principles that we are trying to do with our HealthLinks trial. I'd like to pay my respects to the traditional owners of the land on which we are meeting, their elders past, present and emerging. And I'd also like to apologise for those who had to hear my introduction twice. For those of you who were here yesterday, we tried to finish on a video of one of the patients that's being provided services under the HealthLinks model. So I'm going to start where I left off because the audio didn't work, and we're going to just start with that presentation.
My major health issue is I have renal failure, which I've been treated for 15 years, and that's why I'm on medication. But recently I had 2 admissions to Sunshine. One was I fell and had skin grafts, and the second one was just recently where I had a bowel infection, septicemia and cellulitis of the leg. I was discharged from hospital, and the next day the leg swelled up, and fortunately I was given the nurse's name before I left, and I rang and she was here within an hour. She assessed the situation, contacted the duty doctor on call and arranged for me to be readmitted to the hospital. Well, I find that I'm virtually isolated from 5 o'clock Friday till 9 o'clock Monday morning, because the doctor's surgery closes over the weekend. And should I need any help then, there is an emergency service where a duty doctor who has never seen me before, knows nothing about me, comes to see me. And it's a long and convoluted process where this new service, they come in, they assess you, they can then determine who you need to see and arrange for you to see them and arrange for the transport to hospital, which is a far better and quicker service than I've ever had before.
You don't know where to go and who to ring and what's next. Like this service, just pick up the phone, just ring them and they'll turn up.
As I understand it, if you ring up and the nurse comes and says, look, you have to see an orthopaedic surgeon or something, they direct you there. Where, how would I do it? I've got to go to my local doctor, I've got to get a referral, and then I've got to find the department. I mean, this is, if they could keep this system going, it's marvellous. It really is. This is the best thing that happened. That nurse was here within an hour. I couldn't believe it.
Thanks to Western Health for letting us use that video. So I'm just going to start talking to you about a little bit about what HealthLinks is. Then we're going to go into a little bit more about the detail of HealthLinks, and then we've just started getting some of the early results from the evaluation, which I'd like to talk to you about. So what is HealthLinks and why do we need HealthLinks? Effectively, HealthLinks is a funding reform that is intended to change the way that the funding works, because there's a lot of issues with the way that activity-based funding works and how it fails to support integrated and cohesive care. The activity-based funding rewards invasive and high-cost interventions, and there is no incentive for health services to deliver integration and prevention activities under that model. Clinicians alternatively need the flexibility to coordinate care and deliver interventions that achieve the outcomes that matter most to patients in the most efficient way. So HealthLinks is not a model of care. HealthLinks is a funding reform that aims to improve care for patients at high cost of multiple unplanned hospital admissions, many who have chronic and complex conditions. It aims to remove the financial incentive to treating episodic conditions which patients present to hospital with, and instead incentivise the provision of effective and integrated models of care that ultimately aim to reduce the avoidable use of hospital services and keep people well in their community and in their home. The initiative is being tested, so it's being evaluated to determine whether this flexible model can remove the barriers that inhibit effective and integrated models of care and also promote innovative models of care that produce better outcomes. So I'm just going to hand over to Chris Hamilton, who's going to talk about the specifics of the actual the funding model and the way that we enrol patients. Over to you, Chris.
All right, now for the data analyst section of the talk, which I figure this is probably the one conference where that might be okay. So this is, the key elements really are that we want hospitals to convert a portion of their existing activity-based funding into a capitated grant. And that funding is based on predicted activity for the next 12 months for that patient. So we're essentially predicting their future use of hospital care and capitating that predicted money out. That funding is to deliver all of the care for that, or all of the hospital care for that patient, including the intervention that we'll talk about. There is flexibility and incentive to deliver earlier and less costly services. So essentially, once the money goes into that capitation grant, if the hospital can keep that patient out of coming back to hospital, they get to keep any of that money. Then they can reinvest that money if they've managed to save some money. Obviously, we're happy with sort of cost neutral but better outcomes, but savings are obviously also good. So we needed to identify the cohort. We wanted to look for the chronic and complex patients that are at risk of coming to hospital 3 or more times, and we were looking for unplanned admissions. So we analysed linked admitted data and emergency data over 5 years, so there's about 1 million records. The characteristics most likely to lead to a hospital admission were identified, so we looked for features, and I'll talk about it on the next slide, that were predictive of future hospital use. And it is important to note that we only had administrative data, so the Department of Health only gets an administrative data sets. There's really only dates and some codes and so on. There's no social determinants, so we don't know if they live alone, we don't know if they've got carers. There's a lot of stuff we don't know, I guess. So the predictive power isn't as good as it could be. But we developed an algorithm that runs across all that coded administrative data. The important point too is probably that the hospitals don't get to choose who's enrolled in that funding program. It's all done by the Department of Health. So we run the algorithm that I'll talk about in a minute, but they do get to choose who they intervene with. Oops. And just a quick slide just to point out, because we're using acute hospital data, we're finding the pointy end of the patient cohort. They're all very elderly and frail, or young people with very chronic illnesses, and there's people with COPD and chronic heart failure, etc. So they are the very sort of sick patients that we tend to find. So the algorithm, just for the technical people, I guess, we did logistic regression and we looked at all the coefficients on each feature that was in our data set. We trimmed away any that had sort of coefficients close to 0, but then we trimmed it down to the ones that are shown up on the screen here, and then rebased the score to the lowest coefficient, so 1 being the sort of minimum score you can have, all the way up to, looks about 11. So essentially a patient who's 65 in our modelling is roughly 5 times more likely to show up in hospital than a 20-year-old. So you can see we ended up with features that are probably not that surprising. It's age group, how much prior activity you've had in the last sort of 6 or 12 months, a couple of diagnostic groups, but nothing. We only ended up with 2 groups. Whether you smoke or not, and whether you live in a residential aged care facility. And you'll see there, if they do live in a residential aged care, they actually get -3 points because they're less likely to come to hospital. And what that means is when you run all that through the sort of the admitted hospital data, anyone with a score of 11 or more, we enrol into the funding program. And so this is just more showing you what happens at a I guess a person level or patient level. They'll generally come to hospital for an emergency admission. That will trigger them into the program because they've scored 11 or more points on the scoring system. And you'll see there, patient 1 came back 3 times in the following year for a cost of $30,000. The next patient didn't come back at all, and so on and so on. And we end up with an average cost across our entire cohort, and that's the cost that gets funded. So everybody gets capitated out the average cost, or the average predicted cost. And I think that's over to you now.
So I just got to find where I'm up to. So with that capitated funding, the hospitals effectively have the flexibility to determine which patients that they will be intervening with. It's important what Chris was saying. While they get the average cost, there are some patients that are much more likely to require those sorts of the interventions that HealthLinks offers, and health services are developing additional sort of decision trees to support them in making those decisions and identify which patients are the ones that they should be intervening with. The interventions are addressing not just the clinical factors, but they're also addressing a range of other social and behavioural issues. The patients do not receive an intervention. The patients who do not receive an intervention continue to access the usual care, and this does raise some moral questions, I guess. Because it's capitated funding and because it's the incentive is there, we certainly the health services are looking for those patients that they can who are amenable to change. There are some patients that we've learned from this evaluation that are not likely to change their behaviours, their readmission behaviours, even if you do offer them multiple different interventions. And it's up to the health services to make those decisions, which do lead to some moral issues. So just moving on to what our evaluation is telling us. I'll just go briefly into the evaluation. It's been conducted in partnership with the CSIRO. It includes qualitative and quantitative data. To date, we've got 2 years of data analysed, but even so, it's still very limited data. The first year was only 4 health services who had all participated for less than 12 months, and in the second year, we've got a full year of data, but still the same 4 health services. In terms of the qualitative data, we're collecting the patient surveys, but unfortunately we've just finished the 6-month survey and we haven't got any actual data out of that yet. We've also done a lot of workforce focus groups at the participating hospitals. Again, we've just got the baseline with some sort of reflections, but we're looking to the next 12 months to sort of be able to see what the change is over time. So I guess what I'm telling you is it's still too early to fully understand the impact, especially on patient outcomes and experiences, but at least we've got a really good solid start, and we're starting to see some things that we can, at least if nothing else, ask some more questions about. Just for the sake of the evaluation, I just wanted to show you the numbers of patient enrolments. You can see this is just over the 4 participating health services. We had over 20,000 patients enrolled over the 3 years. Again, that's the enrolment time is over a 3-year period, so that's split in the colours with the 3 different years. Patients are enrolled until they are excluded, and like Chris said, they're enrolled on administrative data, they're also excluded on administrative data. So if they develop a trauma, or if they die, or if they have services which are too high cost, they become excluded from the intervention and they just return to usual care. It's interesting to note that approximately 30% of the patients become excluded each year, but even at the end of 3 years, so some of our health services are moving into their 3rd year, and they are seeing still a high number of patients that have managed to last over the 3 years. Patients are on average enrolled for just over 10 months. Our evaluation is giving us some interesting patient demographics. And I'm sorry, this slide is a little bit busy, but it shows you that, as Chris said, most of our patients are in the older years, but there's still a relatively high proportion in those middle years, which are sort of the 40 to 70, which is not the frail and elderly cohort, but they're coming in and they're enrolling on a number of significant issues. The socioeconomic, the SES analysis shows that a high proportion of the patients are in the lower socioeconomic groups. We've also done some other work in the department to look at that more broadly to understand where our patients are coming from and what their SES is. And you can also see that the DRGs that they're coming in with are very varied. We've taken out other, and what you can see from this, it's the graph at the end, is that there's a lot of sort of very undefined conditions there: chest pain, other digestive disorders, and abdominal pain being some. So these are often patients that have got no other sort of defined clinical pathway. They're not just the diabetes patients or the COPD patients. And what we've also found is that the patients that are coming in with these characteristics have got other issues that are driving their presentation. So it's not just it's not just the clinical issue. It's homelessness, depression, social issues, insecure housing that are also coming up as driving factors. It's probably important to talk a little bit about the intervention models that are emerging. So with this flexible funding, hospitals have the decisions about not only who they intervene with, but how they intervene. It's not a model of care. We're seeing that these patients still do have a high utilisation of acute or specialist services. But there's some common elements that are emerging that we think are showing some success in addressing the underlying issues of these patients, and that is really providing them with some care coordination and navigation services and regular support services in the community or in their home. So we're seeing regular telephone coaching and telehealth monitoring. Those navigation services, facilitated access back into the existing services, not just the hospital services, but facilitating access into the complex care services, into community services and other social services, financial support services and housing services. We're also seeing different service models emerging, so there's not a one-size-fits-all. Some of our hospitals are engaging more closely, particularly where they've got an integrated community health centre, to use their community health services to deliver those services. Others are accessing third-party providers. If you saw the branding on the Western Health video, they've engaged with a NGO that's very prevalent in Perth, I understand, called Silverchain. And they're delivering those services on their behalf, and they're sort of using the network that Silverchain have with a 24-hour hotline and a suite of nurses to deliver that service. And then others are developing separate business units. Monash has established it's called Monash Watch. It's a telehealth patient care service which regularly calls in to their patients. And of course it's tiered based on the complexity of the patients. What's also interesting is that the services don't necessarily need to be delivered by a clinical workforce. So particularly with the Monash Watch and also some of the other ones, they're looking at alternative workforce models supported by technology and decision trees to enable them to deliver the services more efficiently. I just wanted to, these are a bit basic, but I just wanted to show you the difference. What we think is we see the patterns of activities for the patients. So this first slide is what our non-intervention patients look like, our usual care. They bounce in and out of ED. They have a number of unplanned admissions. They're not accessing those sort of post-acute care or the complex care services or the specialist services. So they're very dynamic and not very. They're not planned, they don't use the hospital in a planned way. What we're finding after the interventions is that their ED admissions are reducing in some of those hospitals, but they're using other services that they're able to access in the primary and community support services. And the bottom line is what we sort of see as the intervention. So that's that care coordination, that navigation that I was talking about, that is actually having an impact on the use of the other services. So just in terms of the results from the evaluation, and I will stress again, these are very early results. Some of our health services are doing their own independent evaluations, and what we're up to now is we need to reconcile the results across our system evaluation to the local evaluation. But our health services are reporting significant reductions in unplanned hospital admissions and in length of stay by around 20% for that intervention cohort. Our system evaluation is reporting a 16% length of stay reduction in one hospital, but variable in others. It's reporting that the number of admission departments are also mixed, again significantly lower in some, no significant change in others. The readmission, which is the time between hospital visits, is higher. Now, I think that this is consistent with international evidence that when these patients do become enrolled, and as Chris showed you, they're very sick when they come enrolled, they're actually requiring a lot of services in the first short period of time because those clinicians are finding that there's lots of things wrong with them, whether it be that they need to get their teeth fixed or they've got something wrong with their arm or their leg, I don't know. But we do surmise that is why the readmission or the survival rates are higher. But we need to do a lot more work. So we want to look at the planned versus unplanned use of hospitals. The evaluation hasn't done that yet. And we need to also look at the comparisons of actual patients over time. That's because that average that Chris talked about is very misleading when you start looking at particularly the breadth of patients and the complexity of some in such a large enrolled cohort. As I mentioned with the evaluation, it's also looking at sort of capturing the perspectives of the workforce and the perspectives of patients, although we don't have that at the moment. We're doing a range of semi-structured interviews and focus groups with 75 baseline participants from the 4 hospitals. The initial feedback has been that it has enabled a more holistic approach to patients' needs and provides the opportunity to engage with patients who might otherwise not be receptive. It provides opportunities for integrated and coordinated service delivery and has contributed to patient empowerment and their capacity to self-manage their chronic conditions at home. In our workshop yesterday, New South Wales talked about also measuring value based on the workforce's perspectives, and I think that the quote there about having the clinicians that are allowed to think outside the box and implement things outside the box rather than being confined to the ways we've always done it reflects on the value that our healthcare providers are seeing in this model. It's also is driving some efficiencies in terms and effectiveness, and it's freeing up the beds in the hospitals to enable the patients that really need to be there to get into the services rather than people that can be treated in the community and primary settings. This isn't part of the evaluation, but I thought it was important to also talk about what our learnings are as a department over the last 2 years. We've learned that encouraging hospitals to change their practice can be challenging, in particular without any new money. While the capitation model intends to incentivise hospitals to change practice, it also carries risk, which means that adopting new models of care and investing in new interventions has been a challenge for our health services. It also takes time to see results. Our participating health services have suggested it takes at least 6 months to adopt new processes and change clinician, executive behaviours. We've also learnt that an incentive model needs to consider the potential for some perverse incentives. One of the features of our model, and I talked a little bit about this briefly yesterday, was that when it was initially conceptualised, there was a concern that it would incentivise patients to push the patient down the road, which is take the capitation money and drive them down to the next local hospital. So we had to build into our model a mechanism to avoid that, which is that all of the funding or the WEIF that a patient utilises comes against the capitation grant, so that incentive is removed. We've also learned that interventions are not a one-size-fits-all, particularly in the context of the health service's own operational capabilities. Our hospitals are very different. Some have very strong ambulatory care service support and others don't. Some have integrated community health. So we've really had to allow that hospital flexibility. And we've also learned that co-design and collaboration are really important. We've got 3 clinical collaboratives. Actually, it's down to 1 now, but in the first year or so, we had 3 collaboratives that met regularly every month, and they would just do these deep dives into what's driving admissions, how can we support it, what can we do differently, and let's share the information. And they've been really useful. So finally, just finishing up on the actual impact in terms of funding utilisation. I've got 2 slides that are from the evaluation. This first one shows that over the time of the evaluation of the time of the HealthLinks model, the overall cost of enrolled patients is reducing. While some of this is explained by regression to the mean, we also are expecting that the alternative interventions are showing some effectiveness in reducing the acute inpatient activity and overall consumption of funding, regardless of whether, and this is important to say, it's regardless of whether the services are financially participating. Now, the point there is that even though we've got 4 health services participating, all of those health services have been on the journey and all of them are continuing to make adjustments and improvements over time anyway. So we're seeing for the cohort, there's a reduction overall. The second one shows the comparing over time of the modelled costs of what these patients were modelled to be utilising when we started the program to what they are utilising in the first year. The interesting thing from this perspective is it shows the financially participating sites, the WEIF utilisation or the funding utilisation on the enrolled cohort is lower now than it was at the time when we modelled it, but conversely, in the control hospitals, the hospitals are utilising higher rates of funding on those patients per patient than was modelled. So we're beginning to see that is really important for us in driving forward with the reform. So, to finally finish up, and I'm almost on time, I think that as Richard mentioned yesterday, and we all know, it's not just about funding. There are a whole stack of other things that are impact on the success of an integrated care, delivering more integrated care. And they're the things that our department is continuing to work on, particularly with the value-based care drive at the moment. So we need to look at which patients need integration and develop some common risk tools and supports for hospitals to identify those patients. We need to also understand what matters to people, what services they would like to receive. We need to identify best practice pathways for target cohorts informed by evidence, and that's the work that we're doing now with our enrolled patients. We're doing some clustering work to analyse what is it that these patients are presenting with, and what are the best practice approaches to responding to those, what are the variety of services that will support them. We also need a workforce that is equipped with digital and collaborative skills to provide evidence-based and integrated care. We need data analytics and improved information sharing platforms, multidisciplinary teams. We need what we were talking about yesterday, outcomes measures, so we can effectively assess if Maurice is doing better, and we need to support our health services in driving and implementing new changes. So I think that brings me to the end of my presentation. We do have information on our website. We've got the results of the 2016-17 evaluation up there, which really are just more of a scene setting, and we're expecting over the next couple of months to be able to release some of the evaluation results from the most recent evaluation. Thank you.
Thanks, Tanya. We've got time for maybe one or two questions from the audience, if there are any. I've got a couple here on the phone.
Given that you said the average cost of care is $11,000 and that the cost is reducing of a bundle of...
Yep.
Yeah, that was what you put on. And given that 30% of the patients come out of the program because there's an average of 10 months, does that mean that your costs are less because your higher cost patients are dropping out of the sample that you're talking about?
No. So what we pay on a monthly basis, so patients are enrolled at a monthly basis.
Yes, I understand that.
And so no, we don't have... Health services are not paid for any activity that's not done over the course of a year.
But if they drop out, they default to WEIS funding, right?
Yes.
So wouldn't that lead to a lower cost of those that remain in HealthLinks, because those dropping out go back to WEIS funding, which is going to remunerate the health service more than if they'd stayed in HealthLinks?
But that $11,000 is effectively the average cost of everybody. So yes, it's sort of built into if they drop out, that's just built into the average. Does that make sense?
That's modelled into the patient enrolment.
Do they go back into the control group?
No, they're excluded. Our controls, we've got separate sites for our controls. They're not at the same hospital. Oh, sorry, I said we've got our control. How we're managing the evaluation is we've got control hospitals, not control groups within hospitals.
Okay, we might have to call an end to this now. Thank you, Tanya.
Thanks.
Thank you, Chris, for your presentation.